afternoon. I'm Dr. Ajaiy, your ENT faculty, and now we are going to discuss about the topic on the recall session, which has been asked in the INI-CET November 2025. So we all know that ENT as a subject has very important MCQs, and every year in the INI-CET exams there will be around 7 to 8 MCQs, and in the NEET exam there will be around 15 MCQs. So I'm just going to recall this, what are the questions which have been asked and how have you faced in the exam, and what are the repeated questions which has been asked every year, so that it will be useful for upcoming sessions also. So we will start with the chapters. We will start with the questions now. The question number 1, it was a 65-year-old male who came with the complaints of difficulty in hearing high-pitched sound. So this patient was having a difficulty in hearing high-frequency pitch sounds. The question which was asked was, which region of the cochlea is primarily damaged? So what is the answer now? So what are the options? Option A, apex of the cochlea. Option B, base of the cochlea. Option C, stria vascularis. Option D, tectorial membrane. So what was the question asked? This patient is having difficulty in hearing high-pitched sounds. Okay, so we know that the cochlea is the organ of hearing, right? We know that the cochlea is the organ of hearing, and we know that the cochlea is around 2.5 to 3/4 turns of cochlea is there. So each region of the cochlea does some function. Just have it in mind. The base of the cochlea deals with high frequency sounds. Okay, the apex of the cochlea deals with low frequency sounds. Never forget this. This was asked in previous year aims also, in the INI-CET exams also. Okay, so don't forget this. The base of the cochlea deals with high frequency sounds. The apex of the cochlea deals with low frequency sounds. Okay, so this is a simple direct MCQ, nothing to get complicated. There is no twisting in this. Direct MCQ. Okay, fine. So what does stria vascularis mean? Stria vascularis is nothing but a blood supply. It is a blood supply from where the endolymph has been circulated. When I make a cut section of the cochlea, I am dividing the cochlea into 3 parts, right? We all know this. One is a scala media, other is a scala vestibuli, other is a scala tympani. Stria vascularis is nothing but it is a one second. Stria vascularis, it is a aggregation. It is a collection of the ultrafiltration of blood vessels, which is present in the scala media. From here, the endolymph has been secreted. So this is stria vascularis. So it is a vasculature and it is not concerned with hearing and all. It is inside the cochlea. Okay. So what is tectorial membrane? So we know that in our cochlea, we have 3 membranes. One is a basilar membrane, other is a Reschn's membrane, other is a tectorial membrane. To make it simple, this is, one second, I'm just changing the color, one second. So to make it simple, basilar membrane will divide the scala media and the scala tympani. So what is the basilar membrane? This is the basilar membrane. This area is the basilar membrane. Okay, so this is the Reschn's membrane which separates the scala media and scala vestibuli. What is tectorial membrane? We know that our inner ear contains hair cells. There will be outer hair cells, there will be inner hair cells, right? So the inner hair cells has to go and rub over a membrane to produce the nerve impulse. So for us, the sound to get converted into neural energy, the hair cells has to go and rub over a membrane. And that membrane is called as tectorial membrane. Okay, so tectorial membrane is important for the stimulant, for the converting the sound energy into neural energy. Okay, but here the question which was asked is, the patient is not having complete hearing loss. The patient is having difficulty in hearing high pitched sounds. That is, he is having just a high pitched sound difficulty. So the answer is option B, base of the cochlea, and this is a repeated MCQ also. Don't forget this. The base of the cochlea is concerned with high frequency sound. The apex is concerned with the low frequency sound. Clear? Okay. So we'll move to the next MCQ. Now, question number 2. Again, this was also a repeated MCQ. Just they have changed the question and they have asked for the T staging. That's it. A patient is diagnosed with carcinoma of the larynx. He is having a CA larynx, carcinoma larynx. Okay, in the right 2 vocal cord. Okay, and the anterior commissure and the anterior 1/3 of the left 2 vocal cord. That is, the carcinoma is starting from the right vocal cord. The entire right vocal cord is involved. So when I draw a picture, Now the carcinoma, assume that this is right. So the carcinoma has involved the entire right vocal cord, and it has gone up to this part of the thyroid cartilage will be here. This is the thyroid cartilage. So here we have one tendon which is connects, that is a Boyle's tendon, Now it has come into the other side of the vocal cord also. Okay, and so this is the picture of this patient. This is a carcinoma involving the right vocal cord. It has gone up to the anterior commissure and gone up to the other side, up 1/3 of the left true vocal cord. Okay. Now with extension, see again the next word with extension into the glottic space, inner thyroid cortex. Obviously, see here from here it has involved up to the thyroid cartilage. Okay, so thyroid cartilage involvement is there. And have it in mind, the right vocal cord is completely immobile. So what is the T staging? This is what they have asked you. Okay, so this is the clinical picture of this the carcinoma larynx, which I have drawn now in the red. For this, what we want to know what are the tumor stagings. We know that we have T1 to T4. We usually follow AJCC staging. We usually follow AJCC staging, and in the AJCC staging, we have a TNM staging system in which T, N, M. So T for the tumor, N for the node, M for the met. So when we stage, they have asked just a T staging. So when you ask for the T staging, just have it in mind. In the T staging, we divide into T1 to T4. So T1 is tumor involving a single vocal cord, one vocal cord. So we divided the, or just have it in mind, T1 is involving the vocal cords, okay, limited to that area. So we divide the T1 into T1A, T1B. T1A means involving a single vocal cord. T1B means involving both vocal cords. Okay. So T2 means involving more than one subsite, that is more than one subsite. So what does it mean? A glottic carcinoma extending into supraglottis. Okay, or a glottic carcinoma extending into subglottis. So more than one subsite, we call it as a T2. So I'm not giving you the entire picture. Just have it in mind. These are the keywords to find it out. Okay. So T3 means have it in mind. T3 means the vocal cord is fixed. If the vocal cord is fixed, the vocal cord fixity means it is T3. Okay. T4 is further divided into T4A, T4B. Okay. T4A means involvement of the thyroid cartilage, or a cricoid cartilage, okay, or arytenoid cartilage, whatever. Any cartilage involvement, we call it as a T4A. T4B means it is inoperable. That is, the carcinoma from the larynx spreading into the esophagus, or carcinoma from the larynx spreading into the mediastinum. Okay, extension is more. It is inoperable. Inoperable. It has a severe extension. Okay. Now with this T staging. With the T staging, what we have done, okay, just go to the picture now. What they have asked now, this patient, it has involved in two vocal cords. Both the vocal cords are involved. Along with that, have it in mind, the right vocal cord is completely immobile. So it means that it has gone to T3. Okay. But have it in mind, there is one more picture. The inner thyroid cortex is also involved. That means the thyroid cartilage involvement is there. If there is a thyroid cartilage involvement, what is the stage? It is T4A. Okay, so thyroid cartilage involvement goes in favor of T4A, that is T4. So the answer goes in favor of T4. Okay, clear? So this is to make it simple. Repeated MCQ, which has been asked multiple number of times. T1, T2, T3, T4. T1, T1A, T1B. Okay. T1A single vocal cord, T1B is both vocal cords. T2, T2 involvement of more than one subsite. Okay. T3 is the vocal cord is fixed. T4 is involvement. T4B they won't ask you. T4A is involvement of thyroid cartilage, cricoid cartilage, or arytenoid cartilage. So cartilage involvement is T4A. Okay. So here the answer is P4. Okay. Here, as a conclusion, I will finish the end staging also. So you have it in mind. The end staging is the same for all head and neck malignancies except two conditions. One is an nasopharyngeal carcinoma, other is a carcinoma of the thyroid. Other than that, the end staging is the same for any head and neck malignancy. It could be oral cancer, oropharyngeal cancer, hypopharyngeal cancer, laryngeal cancer, whatever, the end staging is same. What are the end staging? We divide the end staging into N1, N2, N3. Okay. N1 means involvement of a single ipsilateral node, size less than 3 centimeter. Single ipsilateral node, size less than 3 centimeter. N2 is, we are further dividing into N2 into N2A, N2B, N2C. Okay. N2A means a single node, ipsilateral, okay, size more than 3, less than 6 centimeter. Okay, more than 3, less than 6. N2B means multiple nodes. Okay, size less than 6 centimeters. So it could be even a 2 centimeter. But if there are multiple nodes, there are two nodes involving on the same side. It's a same side, multiple, ipsilateral, anything less than 6 centimeter, it is N2B. N2C means, put in mind, C for contralateral. It could be single or multiple, anything. If it is contralateral, say right malignancy presenting with the left node. Okay. So contralateral size less than 6 centimeter, it is N2C. N3 means it could be single, it could be multiple, it could be ipsilateral or contralateral, whatever. If the size is more than 6 centimeter, it is N3. So don't forget this. If they have given a T staging now, there will be a N staging next time. Probably in the May initial, they will be asking about the N staging. Okay. So it's a very important MCQ. So I have just discussed. Just have it in mind. N staging, N1, N2A, N2B, N3, and N3. And as I discussed, N1 is single ipsilateral node less than 3 centimeter. N2 is N2A, N2B, N2C. N2A means single ipsilateral more than 3 centimeter, less than 6 centimeter. That is something around a node of 4 centimeter. It is N2A. N2B means it is a multiple nodes, same side, less than 6 centimeter. It is N2B. N2C means it could be a single, it could be a multiple, whatever. A contralateral node of size less than 6 centimeter. It is N2C. N3 means whatever the size of the picture, it could be a single or it could be a multiple, it could be ipsilateral, contralateral. If it is more than 6 centimeter, it is N3. So clear with this? This is the TNM staging of a carcinoma of a larynx. Okay, fine. So we'll go to the next MCQ. I hope it's clear till now. Okay. Next MCQ. Okay, this is a bit complicated what they have given. Again, for a ENT PG also, if they ask you, they will be struggling with this MCQ. But okay, there will be one radiological picture has been asked, but the picture was not clear. Identify the labeled structure in the given image. So what they have asked, and they have pointed some area, and they have asked what is the structure. Okay. Now, have it in mind. What is the CT being taken? This is a CT scan. Obviously, this is a CT scan. Okay, this is a CT scan. This is a paranasal sinus which is shown above. You say ethmoid sinus, this is sphenoid sinus, but they have pointed towards the ear area. Okay, so they have pointed towards something in the temporal bone area. Okay, now so when you just see for the temporal bone area now, so we know that this is a temporal bone, this is temporal bone, and this is a temporal bone. So we could see a mastoid arteries which are beautifully pneumatized here. Okay, and this area, this is the external article. See, the picture is not that perfect, but have it in mind. This is the external article. Can you see the outer ear is communicating here? This external article. Okay. Cochlear aqueduct is very, very difficult to see, but we can see a cochlear aqueduct in this area. But have it in mind, they have asked this one. Okay, so this area is nothing but the internal auditory canal. Okay. So when you see a mastoid, when you see this picture, This will be the carotid canal, the first which is going near the masthead. This will be the carotid canal. This will be the carotid canal. And just above, there will be one more depression, which is the internal auditory meatus. Why this is important is any cerebellopontine angle tumors. Okay, what are CP angle tumors? Acoustic neuroma, vestibular schwannoma, these are cerebellopontine angle. That is, we know that this is a cerebellum, the pons will be the cerebellopontine angle tumors. Okay, it occurs in this area near the internal artery. The area which has been pointed is the internal auditory canal. This will be the carotid canal here, as shown here. This will be the internal auditory canal. So the answer is option A, internal auditory canal. Okay, there's not much of a discussion here, just as a direct radiological MCQ. Okay, going to the next one. Okay, so this is again a very interesting one. Which of the following hearing test is not been okay, which of the following hearing tests is not performed in infants? Not performed in infants. So option A, OAE. Is it being done? Is it being done? What is OAE? OAE means auto acoustic emission testing. Have it in mind. This is the best screening test for newborns. Nowadays, the Indian Academy of Pediatrics IAP guideline says that all newborns should have a OAE testing. That means a hearing test. So the hearing test, obviously, we know that the diagnostic test for hearing in newborn is BERA. BERA, brainstem evoked response audiometry, is a diagnostic test for hearing. So if we want to say, or if we want to prove the baby is having some hearing problem, then go for the diagnostic test, that is BERA. But BERA is a time-consuming process. That is, it will take some time. It will take 1 hour to do for one baby. Okay, so in our population, in our government setup or whatever the private setup, if we go and do BERA for all the patients, obviously it's a time-consuming one, and the baby is not going to cooperate. The baby is going to ask for feeds immediately, and she is going to wake up. So obviously for BERA, we give them some sedation also. Okay, so again, as I said, BERA is a diagnostic test. So nowadays we have a screening ABR also, that is done for screening babies. But have it in mind, BERA is a diagnostic test for newborns. And OAE, it's a simple it will just take some seconds to do a test. We just place a probe in the baby's ear, and we can check whether the baby is hearing or not, whether it will come as a normal, whether it comes as a pass or a fail. If it comes as a fail, we need to go for a diagnostic test. Just have two concepts in mind. The screening test of hearing in a newborn, it is OAE. Okay, the diagnostic test is BERA. So these two are must to be done in a newborn child. Must. Okay, on the hearing test in a infant. Okay, so going on to the pure tone audiometry. Pure tone audiometry, as the matter says, pure tone audiometry is, we all know that when the patient sit in a soundproof room, we place a audiometry woofer kind of thing for air conduction, and for mass bone conduction, we test it. But have it in mind, pure tone audiometry is a test for hearing. It is a test for hearing. It is a subjective test for hearing. So we place the woofer in our ear, and we ask whether if you are able to hear the sound, just raise your hand. But how can you ask the baby to raise the hand? Is it possible? It's not at all possible. See, again, pure tone audiometry can be done. We know that it is a test for hearing, but it can be done only after 5 years of age. Before 5 years of age, obviously the child is not going to cooperate, or the child is not going to respond you back. So the answer, so pure tone audiometry can be done only after 5 years of age and not before that. Okay, so this is not performed in newborns. The answer is option C. But what is this last one? Free field audiometry. What does it mean? Free field audiometry means it's a kind of audiometry which is done for newborns. So what we do is we place the baby in a cradle. Okay, in a cradle, and we give sound from all the four corners of a room. And we check that whether the child is able to do that Morose reflex. If you give a sound, the child is responding or give that Morose response. So this is free field audiometry. Free field audiometry is also done for newborns. The type of audiometry done for newborns. Okay. So you can do OAE, you can do BERA, you can do free field audiometry. So the answer is option C, pure tone audiometry, which can be, it is a test for hearing, but it is not done in newborns. It can be done only after 5 years of age and not for younger age. Clear with this? Okay. So going on to the next MCQ. Again, a repeated MCQ. This was asked in previous year exams also, and this is arranged in a sequential manner. And even in my previous class also, I have said this is a very important MCQ. Okay, so arrange the following steps of functional endoscopic sinus surgery in a proper order. So what they have asked, they are checking you whether you know what are the steps of a FIS, functional endoscopic sinus surgery. So have it in mind. What is FIS? What is FIS? FIS stands for functional endoscopic sinus surgery. So what are we going to do in a FIS? We clear out the pathology from the sinus area. So functional endoscopic sinus surgery. So we are doing a endoscopic approach to sinuses and clear out the disease from the sinuses. Okay. So what are the sinuses we know? We know maxillary, ethmoid, frontal, sphenoid. I hope it's clear. Right. So when I'm going to approach for a FIS, once again, so assume that this is orbit once again. This will be the middle turbinate. This will be the inferior turbinate, middle turbinate. I'll just explain you now. So when you just see this picture, so this is a anatomy of the lateral wall of the nose. So we could see, I'm just making a cut section of the lateral wall of nose. So this is the middle turbinate, this is the inferior turbinate, this is the maxillary sinus, this is the orbit we have. Okay, and this is the lamina publicia, which divides the orbit and the ethmoid sinus. So this is ethmoid, maxillary, orbit, this is the lamina publicia. Okay, so this is the middle turbinate, inferior turbinate. So again, in our nose, we have two important landmarks. One is called as the uncinate process. Okay, uncinate process. Have it in mind, the uncinate is a separate bone. It is a boomerang shaped bone. So the color which is marked in green. Have it in mind, this is a boomerang shaped bone. The uncinate process is the first landmark. So uncinate process is a boomerang shaped bone. So behind the uncinate process only, there will be opening of the maxillary sinus ostium. Okay, so the first step in FIS is when I pass an endoscope, I want to see the maxillary sinus. So what I do, the first step in FIS is I'm going to remove this uncinate process. Okay, and that is called as uncinectomy. So the first step is uncinectomy. Uncinectomy is the first step. So once I remove the uncinectomy, once I remove the uncinate, I could see the maxillary sinus ostium. And then what I do, I need to clear the pathology from the maxillary sinus. What I do, I just widen up the maxillary sinus ostium. I just make it bigger. We call it as a middle meatal antrostomy. Antrostomy is I widen up the opening so that I clear out the secretions from the maxillary sinus. Now I have cleared out the secretion from the maxillary sinus, so the maxillary sinus is done. The next sinus to approach is ethmoid sinus. See, again, follow this order: maxillary, ethmoid, okay, ethmoid, anterethmoid, frontal, and the last is sphenoid. And then I need to go to the ethmoid sinus. Again, go to the next landmark. The next important landmark is bulla ethmoidalis. What is bulla ethmoidalis? Bulla ethmoidalis is the most constant anterior ethmoidal air cells. So it is an anterior ethmoidal air cell. That is the most constant. That means we all have this bulla ethmoidal. Once I open up this bulla, I am inside the anterior ethmoid. Okay. So bulla ethmoidalus and then go to the anterior ethmoid area. Okay. And then there will be a basal lamella or a ground lamella. So the assume that this is the anterior ethmoid. This is the ethmoid area. Anterior ethmoid cells are multiple in number, but the posterior ethmoid cells are less in count and they are bigger in size. Okay. The area which divides the anterior ethmoid and the posterior ethmoid. Okay. The area which divides the anterior ethmoid and posterior ethmoid, we call this as a basal lamella or a ground lamella. Then come to the basal lamella or a ground lamella. Okay, once I breach the basal lamella, once I remove the basal lamella, I am into the posterior ethmoid. And then go for the frontal, go for the spinal. Yeah? These are the steps in a FIS. So the first step in FIS is uncinectomy and then middle meatal antrostomy. So you are widening the maxillary sinus and then go for the ethmoid area, remove the bulla. Once I remove the bulla, I am in anterior ethmoid. And then if I want to go to the posterior ethmoid, I remove the basal lamella and then go to the posterior ethmoid. Clear? Now coming on to the this one. Our question. So uncinectomy, bullectomy, open maxillary sinus, ethmoidectomy. So now what I said, the first step is uncinectomy, and then what I said, the middle meatal antrostomy. That is, we widen up the maxillary sinus ostium, and then we open up the bulla ethmoidalis, and then we do a ethmoidectomy. Okay, so the answer is A, C, B, D. Okay, so the answer is option C, A, C, B, D. Clear? Yeah? A very repeated MCQ. Just think and answer is a very easy one. And the previous year papers, it was asked, what is the first step in a FIS? The first step is uncinectomy. Now they have asked arrange it in a sequential manner. There it is. The answer is A, C, B, D. Yeah. Moving to the next MCQ. This is again a repeated image-based MCQ. This was asked in NEET also in the previous years. Direct MCQ. Procedure shown in the image is intended to block which nerve? Simple direct MCQ. Just see it. Just see where the injection is placed. The injection is being done in the palate. Is it clear? Injection is done in the palate. So what is the answer with the palate here? The answer is greater palatine nerve. Don't get confused. We are not going to deal with the ethmoid now. Is the ethmoid here? The ethmoid is not here. The ethmoid is here. Okay. Nasociliary nerve, it is supplies nasal septum. It is not coming here. Okay. It's a direct MCQ. You are going and blocking the palate. Something you are injecting the palate. So the answer is greater palatine nerve. A direct MCQ. There is no doubts, no change of option. For a nasociliary nerve, we inject it over the nasal septum. For ethmoid nerve, we inject over this area. So for greater palatine, we identify the greater palatine foramen here, and we just inject just lateral to that area, so that we are anesthetizing the greater palatine nerve area. Okay. For a FIS, if we are doing it for a functional endoscopic sinus surgery or any calval look approach, if you are doing in local anesthesia, then we give this kind of greater palatine nerve block. Clear? A direct MCQ, not much of a discussion here. So going on to the next MCQ. Okay. So which of the following structures is not typically associated with dysphagia or a dysarthria? Okay. They have given the image also. Okay. But not this image. Actually, this is not the A, B, C, D being pointed. Okay, just have it in mind. Have it in mind. This is a direct MCQ. Just forget the picture. Which of the following structures is not associated with dysphagia or dysarthria? Just see the option. Dysphagia means difficulty in swallowing. Dysarthria means difficulty in pronunciation of voice. So now, what are the structures you want to have in mind? So option A, genioglossus. What does the genioglossus do? Have it in mind, genioglossus. Genioglossus. Glossus means it is a muscle of the tongue. We know that. So this is the safety muscle of the tongue. That means The function of the genioglossus is, have it in mind, it is the one which does the function of the pulling the tongue in and out. Okay. So genioglossus is one of the safety muscle of the tongue, and have it in mind for you to have your food. Say for dysphagia, for us to have our food, we need to, when we want to have our food, the tongue has to push the food inside. So genioglossus is a very important one for having our food. So never forget this. Okay. So genioglossus is needed. If there is some problem in the genioglossus, then the patient is going to have a dysphagia. Okay. Posterior pharyngeal wall, is this needed? Obviously, see, whatever we swallow, okay, what happens? Our teeth grinds it, it goes to the tongue, our tongue pushes the food back. Once it pushes the food back, it goes into the oropharynx, and then now our soft palate, we know the structures in the oropharynx. We have a soft palate, we have a uvula, we have a posterior pharyngeal wall, we have a tonsillar area. So these all will push the food into the hypopharynx. So and then the food goes into the pyriform fossa and goes into the postcrica and then goes into the esophagus. So this is how we swallow the food. So now posterior pharyngeal wall is very important. Say if obviously don't get confused. Say we have a pharyngitis, we have a severe throat pain. Can we go and have some biryani there? Obviously it will be burning for us, right? The posterior pharyngeal wall is very important, very, very important for our food swallowing mechanism. And then soft palate, as I said, the soft palate, it pushes the food. Soft palate is the one. Soft palate, it goes up and down, so it makes the food propel down into the oropharynx and propel down into the hypopharynx. So soft palate is also necessary. Option D, nasopharynx. Is nasopharynx necessary for a food pipe? Nasopharynx is the area behind the nose. This is the nose, this is the nasopharynx. What is the function of the nasopharynx? The function of the nasopharynx is, it's not swallowing, it is breathing, it is an airway. So whatever the air which goes from the nose, it goes into the nasopharynx and then goes into the oropharynx. So nasopharynx is not connected with the food pipe. Nasopharynx, the function of nasopharynx is airway and not a swallowing. So the answer is option D, nasopharynx. Clear with this? Clear with this? Any doubts in this? So dysphagia, they are asking about the swallowing mechanism. Nasopharynx, why it's here? Nasopharynx deals with the breathing, not with the swallowing. Clear with this? Fine. So these are the MCQs which has been asked this year in the INI-CET exams. And see, again, there are repeated MCQ also. As I said, the carcinoma of larynx. Every year there have been some MCQs from the carcinoma larynx. Okay, they are asked about the T staging now. Probably in the next time they will ask about the N staging. In the previous years they have asked about directly. They didn't ask about the staging. They asked about total laryngectomy or the patient presented with a T4 larynx. What is the role of management? And in the previous year exam they have put on a total laryngectomy. They put on a TEP picture, tracheoesophageal process, and they have asked what is the surgery being done. So every year there will be some MCQ from the carcinoma larynx. The second important repeated MCQ, there will be one MCQ from the hearing aspects. Last year there was an audiometry picture. In the NEET exam, there will be surely one audiometry picture. This time they have given a repeated MCQ, that is, which is concerned with the high frequency hearing loss. So these are very repeated MCQs. Okay, so there is not much of a difficulty here, except that radiological image which has been asked, and other things they are repeated MCQ. So all the best for the upcoming exams. Thank you.